Good Morning Kenya gets to continue. Thank you for staying with us. And now we are into our health segment. Today we'll be getting to understand something that I feel we should get to know about. That is occupational therapy. Yes, our topic is understanding occupational therapy, and joining me in studio is a clinical occupational therapist from the Kenyatta National Hospital. His name is Mickey Baron. Welcome to the program.
Thank you very much.
Yes, and Mickey is here to help us understand what exactly is occupational therapy, how does it help, and who exactly does it benefit. Welcome to the show, Mickey. It's a pleasure to have you here. Let's start. So what is occupational therapy?
Thank you very much for this opportunity. Well, occupational therapy falls under medicine and rehabilitation medicine. When we are talking about rehabilitation medicine, we are talking about, according to the World Health Organization, we are talking about the combination of the medical model, the social model, and the educational, vocational model, just to retrain and train individuals with lost functions. So where does occupational therapy comes in? Occupational therapy, we look at the three variables. That is the medical model, the social model, how we engage, how we participate in our social context, and then we are looking at the educational model. We are looking at how do people engage in the occupations, that is schooling or in the educational institutions. So occupational therapy basically is the intervention that focuses on promoting functional independence through occupations. So our main focus, we focus on three areas, or the three variables. We have the compensatory methods. Compensatory methods, these are just strategies and interventions that we do of our patients so that they be able to engage in various activities of life. And then we have assistive technology. As occupational therapists, we are looking at assistive devices like the crutches, wheelchair. We're going to discuss more as we continue, especially on matters splinting. And then we are also we are looking at adaptation, that is the environmental adaptation, to enable somebody who has lost function to at least engage meaningfully in the environment.
All right, so that basically is occupational therapy.
Yes.
Is there a difference between occupational therapy and physical therapy or physiotherapy? Is there a difference between the two, or it's one and the same thing?
Good. Thank you very much. This is a question that has really brought a lot of confusion in the medical field. And occupational therapy and physiotherapy are two different cadres. The physical therapists, they are responsible for ambulation and mobility. But occupational therapy, I'll talk more about occupational therapy. As I said, occupational therapies, we use occupations to rehabilitate or to promote functional independence. So what are these occupations? What are these things that we are calling occupations? Occupations are things that you need to do as an individual. If it is education, if it is, having a family, good health, the things that you require to do. For example, if you are a dad, your role as a father is to take care of your family, to provide for your family. So if you have any limitation, any medical or neurological condition that is hindering you from performing this role as a father, then you need an occupational therapist. Yes.
Okay. So the difference between physiotherapy or physical therapy and occupational therapy is that physical therapy helps with the mobility, and that's it. But occupational therapy helps with the day-to-day activities that one is supposed to be or should be engaging in the occupation. That's it.
So we focus on occupation, and we look at occupation as a means. When you're talking of occupation as a means, these are various interventions that we use to rehabilitate our patients. And occupation as an end is we want you to be able to perform a certain activity. For example, you are a student. By bad luck, you got amputated. your upper limbs were amputated,
Yeah.
and you will want to go back to, to school, writing, reading. So the occupational therapist, number one, is to deal with your physical abilities. Remember the uniqueness between physio and occupational therapy, is we look at the physical abilities, we rehabilitate your physical abilities, we also rehabilitate your social abilities. So when you're talking about this child or this student who has been amputated, we are looking at school. How will this patient engage in this activity? So we are going to look at now the assistive devices, the assistive technology I was talking to help this patient, engage in the activities. For example, writing and, reading and etc. So we are on a list. We use holistic approach. That is the medical bit of it, the physical bit of it, the social bit of it, the cognitive bit of it, how you process information, and your mental well-being. Okay. So OT looks at all that.
Okay.
Yes.
So what are some disorders, or let me call them conditions, that occupational therapy actually, helps treat?
Well, occupational therapists are involved in the entire lifespan of a human being. And we look at neurological dysfunctions. Neurological dysfunctions, these are basically diseases that affect the nervous system. The nervous system is the backbone of a human being. We have the central nervous system, which is, we have the brain, and we know the brain is like the engine of a human being.
It is.
Yes, it deals with all the activities that a human being needs to work on. And then we have now the spinal cord that also helps in, sensation, nerve supplies, etc., etc. So if any patient, if you have a medical condition, it can be diabetes, it can be cancer, it can be hydrocephalus, it can be cerebral palsy, any condition that is affecting your nervous system, you will require an occupational therapist. So how does somebody get to arrive to a neurological dysfunction? We have acquired neurological dysfunction where somebody wasn't born with this kind of conditions. Either they acquired it through road traffic accident, through traumatic brain injuries or assaults or traumas that are there. And then we have those neurological dysfunctions that are congenital or are hereditary. So we have people who are born with certain abnormalities or certain conditions. For example, we have cerebral palsy, children who are born with cerebral palsy. Yes. So we see everything. When it comes to the neonatal stage, we come in with the early intervention when we are looking at if a mother has given birth, has delivered, and a child perhaps maybe has some abnormalities. For example, the child has been born and the child cannot suck or cannot breastfeed. And we know the importance of exclusive breastfeeding. So an occupational therapist working in a clinical setup in the inpatient, that is the wards, is stationed in the newborn unit to stimulate the reflexes that enables the child to suck. So if an occupational therapist is not involved in the care of a patient, then it means this child will not be able to breastfeed. It means the child won't be able to get the necessary nutrients that is required for proper brain development and basically brain development. So occupational therapists are critical and they are crucial during the first onset of life till the end. Yes. So we are looking at the newborn cases. If the patient has been discharged, let me say in the pediatric world, children, when we're talking about children now,
Yeah.
we are looking at various disabilities that come up. So occupational therapists, we play a critical role in the preventive measures. We want to prevent disabilities from occurring. And that's what I was saying, we are critical when it comes to the natal stages.
From the onset. Yeah.
Where if we stimulate the reflexes, this child is able to suck. If a child, for example, wasn't able to cry, it means the brain did not receive enough oxygen supply. It means the brain does not know how to function or to operate well. So the occupational therapist, from the early intervention phase, the occupational therapist starts to do therapeutic approaches or therapeutic interventions, like basic exercises, physical exercises, basic stimulation of the sensory nerves, the nervous system. We are talking about the relationship between the mother and the child. So the occupational therapist facilitates that. So when the child continues growing up, we have neurodevelopmental disorders. Neurodevelopmental disorders, their onset is, they basically begin before preschool era. This is where at the age of 2 years, 3 years, parents or individuals start noticing that their children or their babies, they have some deficits. And these deficits are characterized by poor performance of activities of daily living. That is, when it comes to feeding, you find that children are unable to feed. Feeding entails taking food from the plate, putting it into your mouth, chewing it. So because the mouth is one of them, is the major component of feeding, occupational therapists are specialized in oral motor facilitation. So when there is any deficit, if there is weak muscles around the oral region or the mouth region, any sensory deficits, then the occupational therapist comes in to be able to tackle this issue. Yes. So the occupational therapist deals with the oral motor region. That is it. And then when it comes to academics, you find that most parents, they realize at 2 years, 3 years, they realize that, oh, my child cannot call my name. My child does not behave.
There's that, the delayed speech that you get to hear with most parents. Maybe they say, okay, I feel like my child has delayed, in terms of him or her starting to, use words and whatnot. Is that also something that occupational therapists deal with?
Yes, and I'll pick it up from this angle. We look at the developmental stages of a child. And developmental stages, how will you want to realize that or identify that your child or somebody is delayed developmentally? We look at 1 year and below. If your child does not achieve a certain milestone, for example, at 0 to 2 years, a child is supposed to be able to have head control, supposed to support the head, not the head falling sideways. At 6 months, a child is supposed to sit. So you find out that if your child is unable to attain these milestones, then you need an occupational therapist. So the occupational therapist is to come up with the various frames of references, of the various approaches that will aid this child to achieve a certain milestone. So when it comes to delayed in speech, I've been interacting with a lot of parents in the clinical setup, and one of the tricky part is that when a parent sees a child is delayed in speech, they think a child has a condition called autism spectrum disorder, and this is not the case. Speech delay is just a communication disorder and a language disorder. It does not mean if your child is delayed, then they have autism. Yes. So you basically need occupational therapy initial baseline assessment to get to find out your child is delayed in various stages. What can we do, and what are the various personalization or individualized approaches that we can use to promote your functional independence and your meaningful engagement in occupations. And as a child, the occupation is play.
Yeah.
Yes.
All right. Speaking about that, you know, occupational therapy also involves, you know, using assistive devices.
Yes.
So maybe what are some of the aids that are used in OT?
Okay. When you're talking about assistive technology or assistive devices, these are external devices that are either placed on a body part.
Yeah.
It can be your upper limbs. When I'm talking about upper limbs, your hands, your lower limbs, it can be your legs. So we do fabricate an assistive device called splinting. When you're talking about splinting, this is a thermoplastic material that we use to just aid in, you know, protecting the part of the body that is affected. Number one, the importance of splinting, number one is it protects weak muscles. So if you're paralyzed and maybe you have stroke, you have muscle wastage, the muscle dystrophies, we fabricate splint to aid in to protect your weak muscles. Number one, to protect or to strengthen your muscles. Number two, we use splinting for positioning. For somebody to engage in therapeutic or occupational based activities, we have to have a functional position. So functional position means a position that will enable you, if it is taking water from this cup and maybe you have a hand issue. So the occupational therapist is going to fabricate a splint called a hand resting splint just to promote the functional independence, to enable you to use your hands.
Okay.
Yes. And when you're using your hands, the splint is able to enable you, you know, to make those exercises. If you're having a dynamic splint, when you're having those therapeutic exercises, remember I said occupational therapy, we use occupations, practical activities. The Swahilis say occupational therapy ni tiba kwa njia ya vitendo au tiba shughuli. We do practical things. We fabricated this splint. We have various types of splint, the dynamic splint that will enable you, you know, do the physical exercises, and at the same time you're able to, you know, engage in various occupations. For example, if you want to hold a cup, you're able to hold the cup and drink it. So the occupational therapists, when it comes to hand, we are hand specialists, hand therapy specialists. So we look at the hand functions, we look at the prehensile patterns, the various patterns. If you want to open a door, you have to, there's a way you have to hold the key and you know, unlock it. If you want to hold a cup, there's a way you're holding it. So if you have a limitation, for example, you have a tendon tear, and they've done tendon repairs, of course, and you need to go back and, you know, hold your cup. So the occupational therapist is to do those basic exercises and engage you in therapeutic activities so that your brain is able to register this skill, this new skill that we are trying to train it or retrain it. Yes.
Are these conditions common? You know, being that you've worked in this space for a while now,
yes.
Are these conditions that are common in our hospitals?
In our hospitals, they are quite common. The sad thing is that I feel like occupational therapy has not, there's a lot of advocacy that has come up on matters of occupational therapy, but still we've not gotten into, you know, the in-depth of healthcare system. So we have various conditions. As long as you come to the hospital, in advanced countries like the US, when you come to see a doctor, a general practitioner, the occupational therapist is always there just to look at your functional abilities, your level of functioning. Yes, you have malaria. Yes, you have bronchitis, you have TB, blah, blah, blah. And this disease or this condition has hindered you from performing or from engaging in what you'll want to do, you are required to do, and you need to do. So the doctor will look at the general medical assessment. Remember, doctors fall under curative medicine, as we fall under rehabilitative medicine. So when the doctor is assessing you on matters, diagnosis, and trying to find out the investigations that the doctor is doing, the occupational therapist is supposed to be there side by side to know when you are admitted. When you're looking at the occupational therapy process, when you are admitted, we look at the screening, the assessment. The occupational therapist is now able to look at what are your activity levels, what are your activity demands. And because you are ill in a way, how can we facilitate your engagement in the various occupations? Yes, so that is a gap that I'm finding it in the country, where the general medical practitioners, the clinical officers, the nurses are not involving occupational therapists in their treatment when they are that initial encounter with the patient. So I feel like it is high time because we are moving away from the medical model. The medical model is still there, but currently we are moving at the right-based approach, where everybody is empowered, everybody knows their rights. Yes, and if the occupational therapist is not involved in the care plan, then there might be a mess somewhere.
So we still have a lot of advocacy to do when it comes to occupational therapy, right?
Yes.
Because I'm imagining a condition like someone being bow-legged, right?
Yes.
This is something that can be corrected by an occupational therapist, right? From the very start, maybe from the, from the child growing, just them from being a baby, you get to notice that. But unfortunately, maybe some of these things just pass because there's not enough awareness. There's the cleft.
The cleft part.
It also can be sorted, by an occupational therapist. There's the club foot.
The club
like
foot,
things that, we unfortunately still see grown-ups with, and these are things that could have been corrected, way back then. So what you're saying is we still have a lot of advocacy to do on this.
We still have a lot of advocacy. And we, as occupational therapists, we use an approach called the interprofessional approach or collaborative approach. What we mean is that we collaborate with other cadres, like the orthopedic trauma, the orthopedic technologists. We partner with them in managing patients. So for example, when it comes to club foot management, we have the orthopedic trauma guys who make plasters, and the occupational therapists are able to do the physical exercises, just to do practical activities to enhance the child's bow legs or the club foot to be corrected well. When it comes to cleft palate, of course, it can be corrected with surgery. But now when it comes to rehabilitation, remember, cleft palate hinders a person from feeding, engaging in an occupation that is feeding. So that's where the occupational therapy comes in. The occupational therapist accesses your oral region and looks at how is the plate, how are you able to, how are you able to facilitate the muscle strength, the muscle power to enable you suck or to eat or chew and swallow food. Yes. Okay.
You also mentioned that occupational therapy also deals with the brain and the mind and all that. So can it help with mental conditions like that are common, like something as simple as, or let me not use the word simple, something as common as anxiety or depression? Does occupational therapy play a role in this?
Good. This will take me back to the history of occupational therapy, where we began. Occupational therapy began in the 1700s, where occupational therapists were like human rights advocates. And during that era, the mental illness or mental psychiatric conditions were really stigmatized and they were really isolated. So occupational therapists by then, they came up with engaging these patients in meaningful activities, and the result, the outcome measure was these patients, they felt, meaning in engaging in life. They came back to reality. And in the 1800s, we have our father, the occupational therapy, the founder of occupational therapies. In fact, he was a psychiatrist. Okay. And William Rush Danton, he's the father of occupational therapy, he believed that people or patients are supposed to be involved in occupations. Occupations are as basic as food and drinks. So we need to engage our patients in meaningful occupations so that they are able to have well-being in their mind, they are able to have physical well-being, they are able to have social well-being, and they're able to feel, loved and engaged in a community. So occupational therapy, from the onset, we came from the mental health side of the field. So basically, we are involved in the mental health. When you go to Kenyatta National Hospital, we have a very well-equipped mental health facility in the KPCCC, where you will find out that occupational therapists, we have occupational-based therapeutic activities. For example, we have netball. Remember, occupational therapists, we are looking at the 4 domains. We are looking at the social, the medical, we are looking at the physical. So we have activities like volleyball playing, football playing, we have indoors activities. Remember, these occupational-based activities are used to bring this patient back to reality. If you had anxiety or if you are depressed. Remember, one of the clinical features of depression is an individual isolates himself. Either they are all indoors, they're only watching movies, TikToks, they're doing TikToks, they're doing videos, and they do not want to engage outside. So when we get such a patient in a clinical setup, the one role of occupational therapist is to make an individualized treatment care or treatment plan. To make sure, yes, we have the nurses, the doctors who are giving up to the pharmacological intervention, the medications, but the occupational therapist is looking at the non-pharmacological intervention. What are these practical activities that the patient can be engaged in so that at least they come back to reality? If you are depressed, you are detached from reality. But if you start engaging in therapeutic activities, football, things that you love, playing games, you'll come back and you'll start engaging in meaningful occupations. And that's why all psychiatric conditions, it doesn't matter if you have borderline personality, if you have substance use disorder, you require an occupational therapist so that you'll be able to engage in your various occupations. Okay.
Yes. Do you have enough, just out of curiosity, do you have enough occupational therapists in the country?
Well, currently, occupational therapy, number one, this training began in the 1915s. So occupational therapy has been there throughout. We have institutions that are offering occupational therapy training, like the Kenya Medical Training College. We have collaborated as Kenyatta National Hospital has collaborated with the Kenya Medical Training College. We have the JQAT. We have the Presbyterian University that are training our occupational therapists both in the diploma level and in the degree level. So we collaborate with these training institutions. As Kenyatta National Hospital, we train them. So as Mickey Baron, I am a clinical trainer, instructor. I train occupational therapists in the country so that they are more effective and competent. On matters, if we have enough occupational therapists in the country, we have occupational therapists. The matter is, I talked about occupational therapy, we've done advocacy, but the visibility is not there. And right now, disability, impairment, special needs is really coming to arise. And one way that the government, either the Ministry of Education or the Ministry of Health, can collaborate is to employ occupational therapists so that they are able to work in a clinical setup to sort these occupational dysfunctions that our clients have, or to have occupational therapists working in a school setup to enhance, participation in school activities. So the issue is now the absorption of occupational therapists. We need occupational therapists to be absorbed, and universal health coverage is giving us that leeway. But it is high time now the Ministry of Health to advocate for more occupational therapists to aid on the special needs, you know, the disability population. Yes.
Okay, I hear you on that. Now, maybe what role does the family or the caregiver play in all of this, you know, in the therapy process of a patient?
Of a patient. Thank you. Occupational therapists, we use a certain approach called community-based approach. So community-based approach is a community-centric approach where we use a scientific perspective as occupational therapists, but also we advocate for empowerment and capacity building of caregivers and parents or persons living with disability. So how do we collaborate with this cohort of people? Number one, we do a lot of partnership as occupational therapists. We are partnering with support groups for parents with children with special needs. We have WhatsApp groups that are there, Facebook social media groups that are there. Occupational therapists are there just to guide them, to help them psychologically, to give them the right pathway of intervention. Yes. So how do we involve our patients? When you come for treatment at Kenyatta National Hospital, that is occupational therapy, number one, we look at the occupational therapy process. The occupational therapy process, these are just the stages that we follow during our intervention till the discharge. So when you are referred to us, well, the beauty of occupational therapy, you can just walk in. You don't need any referral from a doctor or any specialist.
Take us through that process.
Yes, so the occupational therapy is, you walk in. At Kenyatta National Hospital, we are stationed at the tower block, the old hospital tower block. So when you just enter, if you see that there is somebody who is unable to perform their self-care, dressing, toileting, grooming, there's somebody who is unable to go to work, perform, be productive enough. There is that person who has issue with the leisure. They cannot no longer participate in occupations that they love doing. We have children who cannot play. We have people who have sleep hygiene issues. We have people who have educational issues. So when you come, when you see that somebody has a deficit in all these components, you need to come to an occupational therapist. Just walk in. The second process that we will do screening. Screening, we're looking at the eligibility criteria. How eligible are you for our services? Is it something that we can just educate you and give you home programs to give out carryover skills? So we empower parents. You can go and do this at home. If you see it does not work, you can now come back. You come back, we now start the assessment process. When we are looking at the assessment process, we are looking at the standardized assessments. Standardized assessments, these are approved, tested tools that we use. As Kenyatta National Hospital Occupational Therapy Department, we have formulated our assessment tools that aid us in finding out the pertinent needs of our patients. We have the non-standardized assessment tools. Non-standardized assessment tool, you will find an occupational therapist maybe working in the periphery, maybe a place like Isibania, there is no enough resources. The occupational therapist will use a non-standardized assessment tool, where now we'll use interviews and observations, asking you questions just to find out what are the areas that are amiss. So when you are doing our assessment, occupational therapists are looking at the various domains. Domains, these are just rules and frameworks that guides an individual's work. So we look at the areas of occupation that I've talked about. We look at the client factor. We look at the belief of a client, the values of a client. We look at the physiological processes, the body function. We look at the anatomical structures, the anatomic structure. We also look at the performance skills. When we're talking about the performance skills, we are looking at the perceptual skills. Perceptual skills, when we were in high school or primary, we were taught on the 5 senses, smell, touch. So as occupational therapists, the books says that human beings process information through all these senses. For you, you know 5, as we know 8. So we are looking at all these senses. We're looking at how do you process information. When it gets to your brain, how do you modulate this information? And how do you give out a meaningful output. So if you have an issue with your processing skills, you need an occupational therapist to come in. If you have an issue with your motor and praxis skills, motor, when you're talking about motor, we are looking at the gross motor skills. The gross motor skills are just the usage of the big muscles that helps us in running, jumping, walking. And then we have the fine motor skills that enables us do, writing, just do minute activities. So if you have issues with this, the motor skills, you need an occupational therapist to assess and to intervene. And then when I'm talking about praxis skills is the idea that you have. Right now you're writing something down. There is an idea that has come to you.
Yeah.
And you have that motor planning. You've already executed it. You have the executive functioning. These are complex cognitive abilities. You're able now to write. But if you have an issue with your praxis, for example, you have suffered from stroke and your memory has been affected, your cognitive skills has been affected, your problem-solving skills, judgment skills are affected, you will not be able to process that kind of activity that you have an idea, I want to write down, Mickey Baron, you cannot write. And then we look at the emotional regulation. We have persons with emotional issues. We have children who have temper tantrums, especially children who are on the spectrum, neurodivergent children who have speech delays, who have stereotypic motor issues, and who have emotional issues. So occupational therapists are coming in to regulate that.
All right. Thank you so very much, Mickey Baron,
you're welcome.
For joining us on this conversation. And this is a conversation that should be ongoing. Today we've gotten to touch base on what generally occupational therapy is, getting to understand it. So maybe as the days go by, we'll get into each one of them. Try look at autism, what is it all about? Cerebral palsy, what is it all about? And so on and so forth. So thank you so very much.
You're welcome.
All right, this is where we end this particular conversation. With us in studio is a clinical officer and occupational therapist from the Kenyatta National Hospital. His name is Mickey Baron, and we were speaking about occupational therapy and getting to understand what it is all about. This is where we put a cup. My name is Vivian Degwa. Do enjoy the rest of your viewing. Goodbye.